All right. It is 3 o'clock. So I wanted to welcome um, Brittany Schwarz today. I'll give you her bio in 1 second, but just remember to please stay muted. Um, and if you're having any technical things, you can text me. And then if you have questions, you can put it in the public chat and we will discuss it at the end. But today we have Brittany Schwarz here, who completed her medical education at Creighton Medical School and then went on to Rainbow Babies and Children's for both residency and fellowship, and is now an assistant professor at Johns Hopkins, where she has a clinical interest in neurodevelopmental outcomes of former premature infants and high-risk neonates. She is also part of a multidisciplinary team at Kennedy Krieger Institute that provides developmental follow-up to NICU grads. So we welcome her today to give us some of her wisdom. So I'll let Brittany take it from here.
Wonderful. Thank you so much. So yes, today we'll be talking about beyond the NICU, neurodevelopmental risk and outcomes for premature infants. Nothing to disclose. So imagine that you are the pediatrician receiving a discharge summary for a patient recently discharged from the NICU. What details should you pay attention to if you're trying to identify a child's neurodevelopmental risk factors? This is typically how I approach our follow-up clinic when I have fellows in clinic with me, as well as I typically have a third-year peds resident who's doing their continuity clinic with me. So this is how we start all of our clinic visits. So as we go through this talk, try and think about not only what you need to know as a neonatologist, what you need to pass boards, but really what can you also take away as a teaching point that you can, pass on to the pediatric residents that are rotating through the NICU. So for the sake of this talk, we will really be focusing on the neurodevelopmental risk and morbidities associated with prematurity. Not to say that other diagnoses that we see in the NICU, like HIE or various genetic conditions, don't come with their risk, but that would need a lot more time. So at the end of this presentation, you should be able to list common morbidities experienced by preterm infants that lead to increased risk of neurodevelopmental delays. Sorry about that. Describe the major neurodevelopmental sequelae of prematurity, and efficiently review a NICU discharge summary, searching for key findings that increase a child's risk for neurodevelopmental impairment. So I've approached this talk from two different perspectives based on the various clinical hats that Brooke alluded to. So first, as a neonatologist, caring for these patients in the NICU and working with their families, but also as the recipient of the discharge summaries in my role on the multidisciplinary team at Kennedy Krieger. So in our Infant Neurodevelopment Center, we provide the follow-up for NICU graduates throughout the state of Maryland. And today I would like to impress upon you some of the key information from a NICU discharge summary, which can help you discern risk factors for your patient. And always keeping in mind that this history is not only relevant for their early infancy and toddler years, but really through school age and into adulthood. So for the first half of our time together today, we'll talk through the various sections of a discharge summary with a focus on the pertinent history for neurodevelopmental risk assessment. So take a minute to think about these sections of a discharge summary. What information would be pertinent? What information or complications that the patient did or didn't experience during their hospitalization are relevant when assessing their neurodevelopmental risk? So we'll start by taking a look at the information that's often contained in the general birth history section. So our first question is, what was the patient's gestational age at birth? When we discuss prematurity, the literature often divides it into these 4 categories that you see here, with infants less than 28 weeks being considered extremely preterm, 28 to less than 32 very preterm, 32 to 33 moderate preterm, and 34 to 36 late preterm. The general theme will be that morbidity and gestational age are inversely related. The exact numbers are not as specific, but just recalling that the risk for adverse neurodevelopmental outcomes increases with lower gestational ages. So in 2022, the Neonatal Research Network published updated 2-year-old outcomes data for children born between 22 and 26 weeks gestational age. This reflects data from 19 US academic centers from years 2013 to 2016. You can see that the dark blue represents severe neurodevelopmental impairment, which is often reported as a Bayley score less than 70, and that the rates of this dark bar are decreasing with advancing gestational age. The middle column, or moderate neurodevelopmental impairment, between 23 and 26 weeks remains relatively stable. And then looking at the light gray representing no impairment or only mild impairment, you can see that from 23 weeks through 26, there are increases with increasing gestational age. So we're still in the birth history section, but now you're thinking about being on service and you are being called to the delivery for a 25-week infant. You note that mom received 2 doses of betamethasone over the last 2 days, and you turn to the peds resident who's anxiously waiting with you in the delivery room to explain the benefits of antenatal steroids. So what benefits do you tell them about? I know my first reaction is that this is great for baby's lungs. Let's hope we make it out of the delivery room on CPAP and don't have to intubate the baby. But if I put on my NICU follow-up hat, I then see in the discharge summary that mom received 2 doses, and I'm thinking, phew, this is great news for baby's brain and their overall neurodevelopment. And why is that? So as I'm sure you all know, betamethasone is given to women that present with preterm labor. Certainly, the most immediate effects are that it's meant to help promote fetal lung maturity. But we also know that infants that whose moms received antenatal steroids have decreased rates of IVH and necrotizing enterocolitis, and that there's an associated improvement in neurodevelopmental outcomes. And so it is a nice BOGO that there's multiple benefits from it. And so now we transition a little bit to talking about antenatal magnesium sulfate administration. So we've all said it, mom is on mag for neuroprotection. But what does that actually mean? How is it protective and for which patients? So the exact mechanisms underlying why magnesium is neuroprotective remains an area of active research. But there are several hypotheses, which I think are interesting and helped us to remember, why this works and why it's important. So first of all, magnesium is a non-competitive NMDA receptor antagonist, which means that it can prevent excitotoxic calcium injury in the brain. It also helps to decrease extracellular glutamate in the setting of ischemia, thus reducing the overall excitotoxicity. It can serve to limit calcium influx through voltage-gated channels, reducing activation of apoptosis, in addition to some general anti-inflammatory properties and reducing oxidative stress. So for the purposes of seeing patients in follow-up clinic, the exact mechanism is not the focus, but knowing that overall magnesium is good for baby's brain. So compared to placebo, magnesium sulfate has been shown in multiple randomized controlled trials to reduce the rates of cerebral palsy for children up to 2 years of age. It likely also reduces severe intraventricular hemorrhage. And so because of this, since 2010, Many international obstetrical societies have recommended antenatal mag sulfate administration in the setting of expected preterm birth. This takes us back to our discharge summary, starting with the central nervous system. So what were the head imaging results? So for intraventricular hemorrhage, we know that preterm infants, especially those born prior to 32 weeks, are at increased risk for these intracranial lesions, such as intraventricular hemorrhage and periventricular leukomalacia. And both of these contribute to adverse neurodevelopmental outcomes. So we screen all infants less than 32 weeks with head ultrasounds during their NICU stay. And the susceptibility to the intraventricular hemorrhage is really due to anatomy as well as physiology. So there's impaired autoregulation of cerebral blood flow for premature infants. And this is combined with the fragility of the capillaries that are present in the germinal matrix at this gestational age. So if you take a look at this coronal image of the brain, the germinal matrix is located between the lateral ventricles and the caudate nucleus. The germinal matrix is highly vascularized in the preterm infant and gives rise to neuronal and glial precursor cells. As the fetus approaches term, this area involutes and therefore the risk of bleeding decreases with advancing gestational age. So there's wide variation between institutions as to how IVH is reported by radiologists, whether people are using the PL grading system or using a more descriptive approach. And that is outside the scope of this talk. But that being said, with increasing severity of IVH, it's associated with higher rates of motor impairment as well as cerebral palsy, even after adjusting for other comorbidities. I'm sorry, I'm just going to go back 1 second. So really what that means is, we are still following these ultrasounds in the NICU after the immediate newborn period in order to follow for development of post-hemorrhagic hydrocephalus and to monitor the evolution of the potential white matter injury that's often not evident on those initial ultrasounds. So here, if we talk about periventricular leukomalacia, or PVL, this refers to ischemia and necrosis of the white matter, most commonly in the dorsal lateral or on top of and next to the lateral ventricles. You can see here I have it circled in the red highlights. So oftentimes a radiology report may not explicitly state periventricular leukomalacia. This is something that I try and impress upon pediatric residents as well as when I'm talking to general pediatricians, because if they don't see those keywords, they think, oh, it might not be there, when really many of the descriptive terms such as white matter injury, cystic changes, and sometimes even increased echogenicity may actually mean that there is some evidence of PVL there. And when we think of neurodevelopmental outcomes related to these findings, we have to consider motor delays as well as the effects on cognition. So both IVH and PVL are associated with motor delays. IVH alone is not associated with cognitive delays once we adjust for other morbidities, but PVL is. So PVL really is worse for the brain when it comes to developmental outcomes compared to IVH alone. And there's a direct relationship between the severity of the white matter injury and those outcomes. So if you recall from the last slide, PVL due to complications of prematurity is most commonly in the dorsal and lateral area adjacent to the lateral ventricles. So the area in these black squares. And the lines present on this image represents the corticospinal tracts that control motor function. So as you can see, the tracts that are closest to the lateral ventricles are those that control the legs. And this is consistent with the pattern of cerebral palsy that we see in prematurity, with the overwhelming being a spastic diplegia involving the legs and sparing the trunk and arms. So our head ultrasound results, you still have to take it with a grain of salt, because despite what we just talked about, you know, it's not a crystal ball. And just because, you know, or despite the increased risk for neurodevelopmental sequelae, not all infants with severe head ultrasound findings will go on to develop cerebral palsy. And on the flip side, some infants that have normal head ultrasounds go on to have CP. All right, so we're on to the next section of our discharge summary, respiratory. So this section details exactly when the patient, I'm not sure why it's auto-advancing, I apologize, exactly when they received surfactant, the number of intubation attempts, trials of extubation, transitioning between conventional ventilator, jet ventilator, etc. But what really matters? So when I'm seeing a patient in follow-up clinic, I'm really delving for how long were they on mechanical ventilation? How long were they intubated? And that brings us to bronchopulmonary dysplasia. So as you all know, it's a chronic lung disease that we see in premature infants. It's a result of disruption of the pulmonary development, primarily in the canalicular and saccular stages of development, and can result in direct injury to the lungs from the very technology that we use to keep our patients alive. And so BPD, there are numerous definitions, but commonly can be defined as supplemental oxygen at 28 days of life or at 36 weeks corrected. And there are various classifications of severity, and different studies use different definitions, which makes it difficult to meaningfully interpret the results with respect to outcomes. If you're interested in the specific outcomes, I would point you to Dr. Jensen's group and the recent article looking at definitions of BPD and how it relates to outcomes. But if we try and keep it simple, a surrogate marker of lung disease severity that does correlate with neurodevelopmental outcomes is the duration of ventilator dependence. So the incidence of cognitive impairment, cerebral palsy, blindness, and deafness are all increased for infants that remain intubated after 28 days of life. And this risk increases further with each additional week of mechanical ventilation. So now we're moving through our discharge summary onto the GI section. So did they have necrotizing enterocolitis? So a neonatologist's worst nightmare, a well-feared complication of prematurity that presents as a spectrum of disease ranging from simple feeding intolerance to more severe bowel necrosis and even death. It can require surgical resection. The etiology is thought to be multifactorial. But what I would like to impress upon you is how this relates to adverse neurologic outcomes. So the systemic inflammatory response that occurs in these patients, combined with the potential for hemodynamic instability, ultimately leads to neurologic injury via a cytokine-induced white matter injury. So this is really for surgical neck only. So if you know, regardless of Bell's exact criteria, if you just focus on, you know, did they require surgical intervention or not, is really the difference between whether it's likely to impact their neurodevelopment. And so in the discharge summary, you may see vague or lengthy descriptions about feeding intolerance, neck rule-outs, courses of antibiotics. But what's really important from an outcomes perspective is whether it was medical neck, treated with bowel rest, being on parenteral nutrition and antibiotics, or whether they required surgery. So in surgical neck, the patient's clinical course prompts the surgical intervention, either with a abdominal drain placement or an X-lap that can result in a bowel resection. And presumably these infants have a more significant inflammatory and cytokine response compared to infants with medical neck. So This may explain why we see the difference in the risk for neonatal morbidities. So why they're at risk for these morbidities, such as bronchopulmonary dysplasia, late onset sepsis, and periventricular leukomalacia. And so these patients are at increased neurodevelopmental risk. They have higher rates of cerebral palsy and motor impairment, as well as cognitive impairment. So in general, it's safe to assume that inflammation in the neonatal period is not good for the brain. And so the next complication of prematurity that I look for is in the ophthalmology section. So what was the worst retinopathy of prematurity exam the infant had during their NICU stay? And this is one area that I feel is really important to impress upon our pediatric residents. So retinopathy of prematurity, our infants are routinely screened during their NICU stay. It is the result of abnormal retinal blood vessel development, and early hyperoxia, or I'm sorry, there are two phases to the retinal blood vessel development. During gestation, fetuses are naturally developing in a low oxygen environment. Then after birth, their physiology changes and they require more oxygen. And so they're in a relative hyperoxia environment. This hyperoxia early in life suppresses the retinal vascular growth factors and can lead to a reduction in the retinal vascular development. But as the infant matures, the metabolic activity of the retina increases, and thus, in the setting of a decreased vascular development, the retina then experiences hypoxia, which can lead to compensatory vasoproliferation. And so ophthalmologists will often report this in zones and stages. The zones correspond to the location on the retina, the zone 1 reflecting a circle that's centered around the optic nerve, zone 2 an intermediary zone, and zone 3 being the most peripheral. The stages range from 0 to 5, with 0 simply meaning immature vascularization, not yet showing any disease. And advancing through stage 1, 2, and 3 being mild, moderate, and severely abnormal retinal vessel development, and stage 4 and 5 are the partial and complete retinal detachment that we are trying to avoid. So I historically have found the zones and stages of ROP to be one of the most confusing parts of neonatology. Instinctively, I would think that higher numbers are worse, but it is for the stages, but it's kind of the opposite for the zones. So let's take a minute, and you can really help your peds residents here, but let's take a minute and compare zone 1, stage 3 with zone 3, stage 3. So the stage is the same. You have severely abnormal blood vessel development. But what's different about zone 1 and zone 3? So you can see in the picture, zone 1, it is the central retina. So this is your central vision. And zone 3 is more in the periphery, which would involve your peripheral vision. So I should note that having disease in zone 3 does not mean that zones 1 and 2 are also involved. And I think this is where I used to get tripped up, thinking that the entire retina up until that zone was impacted, when in fact, when you're talking about disease in zone 3, that could mean that zone 1 and 2 are without disease. And so when you put it like this, which is more debilitating, to be at risk for retinal detachment in your central vision or in your peripheral vision? And so when I think about it like this, and I think that losing your central vision in zone 1 would be catastrophic, that helps me to consider that zone 1, stage 3, is worse disease than zone 3, stage 3. But certainly we're trying to avoid retinal detachment in all and any areas of the retina. And so what does having ROP mean for our patients? So having any stage of retinopathy of prematurity is associated with higher rates of strabismus, amblyopia, and myopia. And severe ROP is also associated with cognitive impairment and visual processing or visual motor integration problems. So, severe ROP is rarely occurring in isolation. It's often seen in our most extremely preterm infants who have been on prolonged mechanical ventilation, may have had intraventricular hemorrhage, and this really creates a constellation of risk factors for our patients. So the next time you're in follow-up clinic, consider these questions in the discharge summary to assess their developmental risk. What was their gestational age at birth? What were the head imaging results? What was the duration of mechanical ventilation? And did it cross 28 days? Did mom receive antenatal steroids? Did they have NEC? And was it medical or surgical? What was the worst ROP exam? Did they require surgery? And did they pass their hearing screen? And so now we will talk about some of the specific outcomes. So we've talked about the risk factors. We're done reviewing our discharge summary, and we can shift to talking about the specific neurodevelopmental outcomes. So something that's important for our pediatricians to understand, as well as for the families that we're caring for, is that preterm infants progress through their developmental milestones in a sequential fashion, just like term infants. And what we have to consider, though, is their prematurity in this. And so especially in the upcoming era of our peds residents spending less time in the NICU, I charge you with ensuring that the residents you work with are familiar with the concept of adjusted or corrected gestational age and the importance of using this age as opposed to their chronologic age when tracking their development. And this is till they're at least 2 years old, and some experts might even suggest until age 3. It's also important to prepare families for this. So prior to discharge, it would be great if you're already starting to talk about this, because parents experience a lot of stress when their 8-month-old isn't sitting yet, but their 8-month-old cousin has started crawling. So I often ask parents, when was mom's full-term due date? They all remember the date. And then we talk about how old would the child be had they been born on their due date. And then the light bulb goes on. So I think helping the parents to remember that, oh, wait, I have to imagine, yes, he's 8 months old, but like really, if he was born on our due date, he might only be 5 or 6 months. And I think this is especially important when preterm infants are otherwise doing well medically, because when they don't have that reminder of the hospitalization, they're not on home oxygen, they're no longer taking any diuretics, you forget that they are still a former premature infant, for the rest of their life. And so it's really important to discuss this with families. So now if we talk about the outcome studies that we see. So when the last time you read a study that commented on neurodevelopmental outcomes, what were the outcomes that were reported? Typically, the focus is on adverse outcomes and the degree of neurodevelopmental impairment. Often, NDI is defined as having at least one of the following listed here: cerebral palsy, a Bayley Scales of Infant Development score less than 85, hearing loss, or visual impairment. So before, we delve into the major and minor sequelae of prematurity, let's first spend some time considering the family perspective, because this is the data that we often share with families during our antenatal consults and in the NICU, because it's the data that we have. But is this really what's most important to families? So if you haven't read this article yet, I highly recommend it. Save it, pull it out the next time you have a no-show in follow-up clinic. The title is Parental Perspectives of Outcomes Following Very Preterm Birth, Seeing the Good, Not Just the Bad. And this study was published in 2023, and the authors sought to describe the parental perspective on health and developmental outcomes for their preterm children in relation to the level of neurodevelopmental impairment. So they had 199 parental responses, reflecting 163 children. 44% of those children had been diagnosed with a neurodevelopmental impairment. The median gestational age of the infants was 26 weeks, and the birth weight was 860 grams. So this study, which was conducted in follow-up clinics in 2 Canadian level 3 hospitals, they asked parents to rate their child's health and their level of agreement with various statements about their development, physical health, personality, and social interactions. So as you can see here, on the left, you have those responses of parents that had a child with neurodevelopmental impairment versus without neurodevelopmental impairment. And the darker shading suggests a more stronger agreement. So all parents reported their children were happy and had a positive personality. There was no difference between parents of children with or without neurodevelopmental impairment. Similarly, nearly all had reported the positive personality. So overall, 77% of parents expressed that their child was doing much better than predicted. And this always gives me hope, and I think being in follow-up clinic really helps to give perspective to those really rough days and nights in the NICU. So beyond that, the results did start to differ between the two groups. And this was when parents were asked about their areas of concern. So for parents of children with neurodevelopmental impairment were more likely to express concerns. When it comes to development, the concerns were primarily related to language development. That language was the most common concern. Whereas for physical health, the things that families were reported being concerned about often had to do with breathing or eating. And so overall, even if parents continued to have these concerns about their child's development, they were still happy with their overall well-being. And many families and researchers are really starting to call for more outcomes data that is looking at factors and impacts at the family level and what's important to them in their everyday life. So now if we transition back to what we as a field have traditionally considered as the main neurodevelopmental morbidities of prematurity, we'll talk about the major sequelae and then briefly touch on some of the other sequelae. So the major sequelae being cerebral palsy, sensory impairment, which includes vision and hearing, and cognitive delay. So we'll start with what often gets the most press, even though it's not the most common, but cerebral palsy. So cerebral palsy is a clinical diagnosis. It's a disorder of movement and posture. It's a non-progressive brain injury or disturbance, which leads to a functional impairment. There are 4 different types. You can have cerebral palsy that's characterized by spasticity, dyskinesia, ataxia, or hypotonia. And different etiologies or medical conditions place you at risk for those things. So if you recall from earlier in the presentation, we talked about how for our premature infants, it's really the spasticity, which can present as increased tone. So for cerebral palsy in our preterm population, the vast majority is spastic diplegia, 71%. And again, I bring you back to the corticospinal tracts and the square, which is the most common area for to have periventricular leukomalacia. Not that you can't have it further out, but if there's something that's going to be impacted first, it's often the legs. And so you can also have a small proportion that have hemiplegia or quadriplegia, oftentimes in the most severe cases. So moving to our next major sequelae, so neurosensory impairment, being vision and hearing. So vision impairment, unsurprisingly, the greatest risk is for those with severe retinopathy of prematurity that requires surgical intervention. But regardless of the severity, all preterm infants should have follow-up at 4 to 6 months of age due to the increased risk of myopia, strabismus, and amblyopia. And that's really whether or not they had ROP. Hearing impairment, I'd also, like to impress upon you, this is also relevant for the duration of mechanical ventilation, as well as our oxygen use. And so, be suspicious of your infants that are still on home oxygen after discharge, as those infants are likely most at high risk for hearing impairment. And just because they pass their newborn screen in the NICU doesn't mean that they can't go on to have a more progressive hearing loss. And also, we have to consider that many of the medications that we use to treat our infants in the NICU, such as gentamicin and Lasix, are ototoxic. And then certainly any patient with severe hyperbilirubinemia or any neonatal infection also increases the risk for hearing impairment. And so all kids that are born in our hospitals are receive hearing screens before discharge, but certainly the recommendation is that if they spend more than 5 days in the NICU, they should probably have a repeat audiology evaluation before age 2. And this is extremely important for our extreme preterm infants, where the hearing impairment can be delayed in onset and be progressive. And so really in follow-up or for general pediatricians, having a very low threshold to repeat that audiology evaluation in the setting of any emerging language delays. And then what I'd like to impress upon you today when it comes to the cognitive delay and intellectual disability is really to understand and interpret the studies that report these. You don't necessarily need to know all the details of the instrument they're using itself. Most of them are reporting normalized data on a standard distribution curve, such as the one in this image. And so normal development is going to fall within 1 standard deviation of the mean, so in either direction. And this represents 68% of the population. So have you ever wondered why the Bayley scales of infant development outcomes are often reported as scores less than 85 or less than 70? I know when I was first starting fellowship, I was like, those seem like random numbers to just pick, but it's consistent throughout studies. Well, this is because the mean score on the Bayley for each of the domains is 100 on a normal curve with a standard deviation of 15. So a score of 85 reflects being 1 standard deviation below the mean, and a score of 70 would be 2 standard deviations below the mean. So the other thing is when interpreting outcomes data, it's important to ensure that the authors note how they're defining the various delays or neurodevelopmental impairments. But you will often see that scores between 70 and 85 are classified as moderate delay or impairment, and less than 70 being severe delays. So what are some of the other sequelae that can lead to a functional impairment? And these are often things that we don't talk about as frequently. So the first being developmental coordination disorder. So cerebral palsy gets the most recognition when it comes to motor outcomes, but something we don't talk about as much is this condition. This is considered a minor neuromotor abnormality. It can result in suboptimal motor function, but unlike cerebral palsy, it doesn't have any underlying neurologic abnormality on exam that you could feel or that could explain it. And so it does not meet the definition of cerebral palsy. These children are often labeled as clumsy or have poor coordination. They may struggle with manual dexterity and fine motor skills. So the skills that would be required to snap buttons, to zip a zipper, or even with basic handwriting. And certainly this can contribute to difficulty as you get into school age and can contribute to a functional impairment. And this is seen in up to 37% of extremely preterm infants. And so it is especially important to initiate occupational therapy services early if you suspect the fine motor component. Oftentimes parents ask about athletic potential. Children with developmental coordination disorder may struggle with sports that involved a significant amount of eye-hand coordination and balance. So ice hockey or lacrosse may not be ideal for them, but in settings where you have more repetitive movements, such as swimming or running, these children can be really successful. And so really focusing on their strengths as opposed to the deficits. And developmental coordination disorder, I should mention, is also associated with increased rates of behavioral problems, ADHD, executive dysfunction, and difficulty with social skills. So now we'll talk a little bit about language disorders. So as a whole, preterm infants are at a disadvantage when it comes to their language development. So they typically perform anywhere from half to 1 standard deviation below their term-born peers. This isn't just for our most extreme preterm infants. This is also experienced by moderate and late preterm infants. And it's also not unique to the early years or infancy. This can be continued on through adolescence and certainly can contribute to significant disadvantages with respect to learning and social interaction. And so these disorders may be expressive, receptive, or mixed. And many children with expressive language delays experience frustration and externalizing behaviors due to the difficulty communicating with their caregivers. And so oftentimes there's behavioral difficulties, emotional disorders, and ADHD that can coexist in children with language impairment, which can be really impactful for the family. And so getting early intervention services as soon as possible and making sure that they have a repeat hearing screen so that they can adequately hear, all of the nuances in language to help with their development. And that brings us to the preterm behavioral phenotype. So this is seen in roughly 20% of infants that are born less than 32 weeks. There's an increased risk for ADHD in the preterm population, but it's different than how ADHD presents in term infants, in that in the former preterm infant, it's more likely to be the inattentive type, much less likely to have any associated conduct disorders, and they are at risk for social impairment from this. They can have social anxiety, as well as experience many internalizing behaviors, such as depression. And so this is something that I think is also really important to impress upon our residents, or as well as families, but people who are going to be caring for these patients long after they leave the NICU, because this isn't just something that's going to impact them as young children and can really have a lifelong impact. And so in conclusion, we talked about the increased neurodevelopmental risk associated with white matter injury, mechanical ventilation longer than 28 days, surgical necrotizing enterocolitis, severe retinopathy of prematurity requiring surgery, the need for ophthalmology follow-up regardless of ROP disease, the need for repeat hearing evals after discharge, and to make sure that as the child gets older, to not forget about developmental coordination disorder, the preterm behavioral phenotype, and mental health problems. So thank you so much for your attention and interest. I hope that this provides a perspective that you can take with you to follow-up clinic, during fellowship, even if that's not where you see yourself long-term. Please consider this as a context for what you are, a piece of what you're meant to get out of that experience. And with that, I'll turn it back over to Brooke.
Thank you so much, Brittany. Does anybody have any questions they want to put in the chat? I think that was a very comprehensive talk, but we'll see if anybody has any questions. Brittany, what drove you into this field?
Oh, that's a great question. So,
The developmental piece of this.
yeah. So, when I was in undergrad, I thought I was going to be a college biology professor, and I worked in a group home for the developmentally disabled. And so I was taking care of adults, many of whom their journeys started in the NICU. So some of them were related to prematurity, some were severe autism, and that helped me get interested in medicine in general. And so when I first decided pediatrics and when I was applying to residency at Rainbow, I thought I was going to be a developmental and behavioral pediatrician. And so that has been a long passion of mine. However, I quickly realized that 1/2 day of outpatient clinic a week was the absolute most that I could muster, and that I needed the higher paced, higher acuity, and was drawn to the complex physiology in the NICU. And so I was really lucky, at Rainbow to be able to have a really strong follow-up component and to use that as my scholarly area of focus during fellowship. And then I've been able to continue it on.
Yeah, definitely some of the greats have come from Rainbow when it comes to developmental for neonatal outcomes.
Yeah.
So another question that came up is, how do we balance the concerns, the difference in opinion as outcomes as seen from the parents? So how do we balance their concerns versus the need for continued research in the field?
Yeah, so there, I do think that there are starting to be some studies that are looking at, pain control in former infants, or some of the outcomes discussed in that Canadian study, and even the 2023 article from the Neonatal Research Network alludes to the fact that we probably need to expand what we're looking at. So I do think that that's coming as we have more and more partnerships with families. My hope is that more of that comes out in the research. I think, being able to quantify things and have a comparison to prior studies probably necessitates that we'll kind of always have some of those, more standard, but hopefully we can expand that. And then I think just an awareness of it, I think certainly after that article and then with my experience in follow-up, kind of changes how I approach some of the antenatal consults as well. And so, yes, if parents are asking specifically about cerebral palsy and things, talking about it, but really trying to focus on, hey, can I tell you about, some other families that have, are on the other side of this and are already home and what life looks like for them. And so while we're waiting for the research to catch up, I think that we can already start changing a little bit just about the way we talk to families.
Thank you, Brittany. And just to let everybody know, we do have an April 16th topic. We have Dr. Kamath Rain, who is going to be talking to us from Harvard, who's going to be talking to us at Neonatal Global Health and our efforts at the AAP. So I think that's going to be a very interesting talk of what they're doing at that level, especially in our changing climates. So please join us on April 16th for her talk, and we will see you all then. If there's no further questions.
Fantastic. Thanks so much.
Thank you.
Shout out to my Hopkins fellows that are on here. Thanks, guys.